Hello, my name is Ann Kitchen, and I am on the Austin City Council. I'm going to be talking with you today about this exciting initiative in Austin called the AustinCARES program. It's one of our public safety responses to the mental health crisis. I've been working since my time on council in healthcare and mental health care, in particularly, as a member of our public health committee for our council. And our city of Austin, and our city council has been focusing on healthcare issues, and in particular, public safety, a broader definition of public safety as encompassing healthcare. So we've really, over the last few years, been working on transforming how we view public safety, how we respond to public safety issues, so that we really, as a city, more broadly recognize that public safety encompasses health, and particularly mental health. And this has been, over the years, and particularly last year, this has been part of our efforts to reimagining policing. And that our reimagining policing effort grew out of this perspective of our city that healthcare, and particularly mental health, is a key component to public safety. So I'm going to begin by talking with you about what our strategy is here, to give you an overview of what the AustinCARES program is. So, and you can see here that there's two parts to it. But let me begin by saying that, there are a number of communities around the country, and more communities around the country, that are working on alternative response programs. And most of those provide alternative responses using what we think of as civilian teams, which is actually teams of mental health professionals and emergency medical responders. We do that too. AustinCARES is built on our MCOT program, which is our emergency response program for mental health, in which care teams are dispatched primarily through a hotline to our local behavioral health authority. So improving upon that basic response system for us in Austin required making a policy decision. What we did is we made the decision to add a fourth option to our 911 call, and to triage to determine that a call posed no public safety risk, and clinical triage to determine the best course of action by a non-civilian. So basically, we added an option to our 911 call center, which said mental health. And I'll get into some more details about that. But what we're trying to do now is we're trying to go further than that basic change. We want to go further, and we want to improve response to calls where the situation could be volatile and there may be a public safety risk. So AustinCARES focuses on both situations. We divert calls. As you can see here, our two-part strategy is we divert calls for assistance from a law enforcement to a mental health care response when it's appropriate. But the second thing we do, and this is something that we've seen that is different and is challenging, and that is to aid police in potentially volatile situations to help avoid a tragic outcome and connect people in crisis to resources. So we are both diverting calls where there's clearly no public safety risk, but we're also helping the police, and we're aiding the police in situations that are potentially volatile. So, and that second is the response to the type of calls that require a law enforcement component. Now, the reason we did this two-part strategy is because if we had only focused on the first one, the civilian teams, then we would be missing a big segment of the population, or a big segment of the mental health concerns, mental health emergencies that occur. So what we're doing is we're attempting a cross-agency team approach where we're assisting law enforcement with mental health professionals, in some cases through the use of telehealth or communications technology, and I'll talk more about that. All of that requires rethinking our response modes, being more collaborative, and recognizing that the presence of police is important in these situations, and it's not always for enforcement and it's appropriate. We're also doing something that I'll talk about in a few minutes in more detail, and that's really important to this process. And that's adding an interagency team approach to the follow-up. So this is all about both responding in a mental health crisis with the appropriate personnel, but also following up afterwards. That is really important too, and we're finding that really takes an interagency team approach. So, and without that interagency team approach, then we're not going to really help an individual stay out of that situation in the future. So let me go on so I'm going to talk about the specifics of components of the program, and then I'm going to focus on two key components of the program and also talk about what the challenges are in implementing this program. So I'm going to start here with the recommendations that were made to us by the Meadows Mental Health Policy Institute. You can see here the 6 recommendations. And so I didn't mention before, but the first thing that we did to start on this process is we started with an audit by our city auditor because we were getting indications that they were having difficulties and not responding in the most to mental health emergencies in the most in the best way, or the way that avoided difficult situations. So, well, for us in Austin, there wasn't any single incident that prompted our city audit. There was a realization in our community that we were using police to respond to calls that really didn't require law enforcement. So we did the city audit, and then we followed that with engagement of the Meadows Mental Health Policy Institute to help us analyze exactly what we were doing as a city in responding to mental health emergencies and how we might improve. And the Meadows study showed us what we were concerned about. It showed that even where there was a public safety risk, we were not adequately equipping police to effectively respond. So the Meadows study confirmed that our community mental health hotline was overburdened and insufficient to respond to residents in crisis, and that our community needed a multi-agency approach to mental health crisis response in order to avoid tragic outcomes and deliver healthcare. So what came out of the Meadows Mental Health Policy Institute were 6 recommendations for improving our first responder system. And these 6 recommendations, we are in the process. We've made significant progress on these, and we're in the process of fully implementing each of these 6. So I'm going to run through each 6, and then I'm going to drill down on one of them that's really core to the changes that we're making. So let me say first, Police Chief Advisory Committee function. One of the recommendations was it was very important to have that connection to the community and to have a sounding board for our police chief, a sounding board of individuals who had experience in the community, had some lived experience, and who had connections to our mental health system and our physical health system in the community. So we have done that. We have created an advisory committee function, and that group of people periodically work with the police chief to get feedback on the results and what the data is showing us about how well this program is working and where improvements are needed. So that was recommendation number 1. Second recommendation was training for our call takers and dispatchers, and that's training beyond just basic mental health training beyond a couple of hours of basic mental health training. This is in-depth training so that our call takers and dispatchers can really, truly recognize a mental health crisis and recognize the appropriate response and triage system in that circumstance. The third one is one of the core changes and transformational actions that we have taken under the AustinCARES program, and that is our mental health integrated dispatch with clinicians embedded in our 911 call center. I will talk in more detail about that in the next few minutes, but that is core to this program. The fourth one was enhancing our mobile crisis outreach teams with telehealth. You know, telehealth is a force multiplier, essentially, and it allows for clinicians to actually support our police who may be on the scene when a clinician cannot actually be there or cannot get there. And this is also important in those situations where, excuse me, in those situations where there is a public safety risk and there may be, there may be a weapon involved or there may be something else going on that poses public safety risk, where it's appropriate for the police to be on scene, but they need the support and the guidance of a mental health clinician. So through telehealth communications, the clinician can be part of that response in those circumstances and aid and guide the police. That's another key component of this. The fifth one is collaboration with police crisis intervention teams and community paramedics. This one is also key in the sense that what we're talking about here is recognizing that an interagency response is necessary, both during a crisis and follow up to a crisis. So this recommendation is about creating that system, which is an interagency team with our police crisis intervention team, our community paramedics, and our mental health system. And the way that works essentially is this team triages the follow-up after a mental health emergency. For individuals that are primarily in need of care in the community, mental health care or physical health care, this team serves the function of referring to a community agency or a community mental health professional or clinic. For circumstances that are very complex, that involve both law enforcement issues and the need for mental health care or physical health care, this team handles that follow-up. It's a interagency team with both police and mental health professionals and community paramedics as part of it. And so they handle the follow-up on the more complex cases. For situations where the follow-up is primarily law enforcement, there's not a mental health or physical health care component, that stays with our police crisis intervention teams. So the creation of an interagency team approach as part of this fifth recommendations is key to the follow-up after a mental health emergency, which again is very important for our community because what we're trying to do is transform how we respond and make changes to prevent and hopefully reduce the number of mental health emergencies in our community. The final sixth recommendation was a recommendation that was made with regard to community outreach. What we have determined is that it was very important to think about health disparities in our community and the different approaches and experiences that people in our community might have with the mental health system, with the police system, with the 911 call center. And we needed to be able to reach out to the community to educate folks in the community about what AustinCARES is and what it offers, and also to listen and hear concerns that people in the community might have about how this system operates. So that's a very important component of the recommendations and the component of the program. So I want to say also that at the very beginning of starting down this road, we started with the city audit. We then recognized that we needed expertise to be of assistance to our staff, our police department, our emergency responders through EMS, and our mental health authority. And that's why we engaged the Meadows Mental Health Policy Institute. But we did it in a way that evidenced our commitment as a city council. We funded additional staffing So we funded additional mental health clinicians. We funded our MCOT, which is our emergency mobile response system. We funded additional paramedics. We also funded Meadows to both do this initial analysis and recommendations for us, but also to come back and provide consultation and guidance for implementation and carrying out these 6 recommendations. So that was very important to make that upfront commitment, and at the policy level, and to put behind it the resources that were necessary to make sure that we could implement and be effective in this program. So I'm going to turn now and focus on the mental health integrated dispatch program, which is that 3rd recommendation. This is the core of the changes that we've made in terms of our mental health response. So we recognized in doing that the 911 call center is really the vital triage point, because it really is the first contact that a person makes when they're calling 911. So, and we recognize, as I mentioned before, that there have been times in the past that behavioral health indications are neither understood by the 911 call taker nor passed along to the responding officers. So communication through the 911 call system has not, in a mental health crisis, has not been optimal, either in recognizing that there's a crisis or sharing that information with a police officer who might be going on to a scene. So we recognize that the triage, that function that the 911 call center needed to fulfill, had some significant challenges with regard to mental health emergencies. And of course, the fundamental premise behind this is that a purely law enforcement response is really not the most appropriate response for a person calling 911 in a mental health emergency. So we recognize, of course, that trained licensed professionals were needed, and they play a vital role in triaging the needs that an individual is having in the middle of a mental health crisis, and that really our licensed professionals are the individuals who have the background, the staffing, the expertise to assign a response to the most appropriate resources. So here's what we did with integrated dispatch. We based it on a clinical response. And so integrated dispatch is the core of our response when someone is in a mental health emergency. So what we did is we changed our 911 greeting. Our greeting now is Austin 911. Do you need police, fire, EMS, or mental health services? So that is a fundamental change to the way in which we respond through our 911 call system. And then we staffed with clinicians. We hired clinicians, and they are embedded within the 911 call center 24/7. That means they're on site in the 911 call center 24 hours a day, 7 days a week. The call takers use a decision call tree based on national best practices to decide how to route a call when it comes in. When someone calls and asks for mental health services. The call tree also sort of acts as a safety net. So the call taker also asks the caller if they know or suspect the individual is experiencing a mental health crisis. So when you call 911, people have the option to ask for mental health services. And our call takers also ask them if they are calling on behalf of someone they think may be experiencing a mental health crisis. And so then, so the call tree outcomes really are set up to handle a number of different situations. As you see here, the call tree outcomes are basically 4 different outcomes. So, and those may be a police response, with a clinician on the line as a consult. And that's where, when we say on the line there, we also mean with telehealth capabilities. So that may be a police going onto the scene because it may be a public safety issue, and the clinician is on the line with the police officer and also could speak to the individual who's experiencing the emergency in a consultative role. Second scenario may be just transfer directly to a clinician for crisis counseling when someone calls into 911, and that's the response. The third one I already mentioned was a police response with the clinician providing counseling via telehealth services directly to the individual. So the clinician may be, as in the first response, just supporting the police officer. And the third response may be actually supporting the police officer and actually providing telehealth services to the individual. And then, of course, there are some circumstances where there's not a need for mental health services, and the police response may just be a police response. So this is the core of what we've changed in our response to emergencies, mental health emergencies. So I want to turn now to what have been the implementation challenges. This is a fundamental change to our approach to mental health emergencies. It's a fundamental change in our 911 call system. So because we're creating this integrated approach to crisis response as a fundamental change, it's complicated. It involves multiple systems at differing agencies, and it challenges established work patterns. So to be successful, we have found that it is critical to have policy and executive leadership. The leadership and commitment to system transformation has to start at a policy level, and it has to be a priority, and continually that commitment has to be a priority and continually reiterated at the executive level. But again, it also has to be a commitment to system transformation at all levels. So our mental health clinicians, we have found, really see the value of this approach, as do our paramedics and our police officers. And a commitment to this change at their levels is absolutely critical. And they need the support of their leadership and the support of the policy level in terms of staffing and infrastructure needs and funding. So, and that funding includes funding for external expertise. We feel like it has been invaluable for us to have the support of the Meadows Institute. BJ Wagner, who's an expert in this area and has worked with multiple cities. Her support and the support of the Meadows Institute has been critical. We've also had to fund support for data sharing infrastructure and telehealth infrastructure. There can be some challenges to sharing health data, mental health data in particular. And so it's necessary to have the right protections in place from a data sharing perspective. Data sharing is also critical to evaluating results. If you don't collect data, if you can't share data and can't analyze it, then you're not going to know whether or not the program is successful. And so to do that, you've got to have the systems in place to collect and analyze data, and also the staff in place who understand how to do that. And then, of course, telehealth infrastructure is another area where funding is necessary to support. Just going to quickly run through some of our toughest challenges. They are what you might imagine. Staffing issues can be a concern, particularly now during COVID. There have been concern with staff shortages and reallocations. Staffing is critical. You have to have the right number and level of folks to work in the 911 call center and to follow up with individuals afterwards. So staffing is something to pay attention to, and those are challenges to address. Another tough challenge is really comes from some level of reluctance sometimes to accept new technologies. either through data sharing and telehealth. People have legitimate concerns about sharing health data. It's not something that they're used to doing, and it's something that they want to make sure they do in a way that protects privacy. So, the work is necessary to really help people understand and see and experience the value of this approach to overcome this kind of reluctance. The other thing is, because it's interagency work, that can be really difficult. There has to be agreement on program design and process changes across agencies. So, like any kind of process change, this can be difficult, and it's even more difficult and challenging when it's across agencies. And so we have found that, and one of the value of bringing in expertise from the Meadows Institute has been to help us anticipate and address these kinds of challenges. Because going into this kind of program without being cognizant of and having a plan for addressing challenges will make it much harder to achieve the results expected. So I wanted to close by saying that we are available. My office is available. Our staff is available at AustinCARES to share information. We invite you to reach out to us if you would like. I've got our contact information here. You can also just read the Meadows Mental Health Policy Institute report and recommendations. And I encourage you all to, if you're, congratulations to those of you who are looking at these kinds of changes in your community. I urge you to think about them if you have not moved to this kind of approach in your community. Every community is distinct and different, and these kinds of responses have to be tailored to the structure and the needs of a particular community. But I wanted to say that what we have found to be so important in Austin is, as I said at the beginning, the recognition that emergency response to mental health crisis is a health issue and needs to be addressed in a health issue way. It is, there's an intersection with law enforcement and policing, but primarily this is a health issue, and we need to transform our system to actually respond with mental health professionals and to work collaboratively with our law enforcement agencies to have the best response in a mental health emergency and to prevent as much as we can mental health emergencies from occurring. So I thank you very much for your time, and I hope you've found this presentation helpful.